Good morning. As you know, the definition of poor perfusion states in the low birth weight infants remain controversial. The superior vena cava flow represents the blood flow coming from the upper part of the body, and it has been proposed as a relevant biomarker of circulatory impairment in lower weight infants as it associates adverse neurodevelopmental outcome and mortality. In this context, dobutamine has been proposed as the best therapeutic option. In a small clinical trial where the effect of volume plus dobutamine and volume plus dopamine was tested, it was resulted in a greater percent increase in the former when it was administered volume plus dobutamine as compared to volume plus dopamine. In addition, the percent of infants that resulted in a greater stability of superior vena cava flow at 24 hours of life was greater in the dobutamine group. The follow-up resulted in a lower percent of infants with late severe intraventricular hemorrhage in the dobutamine group. The explanation for that relies on the pathophysiology of the circulatory impairment in lower weight infant. When the umbilical cord is sectioned, there is an increase in the systemic and a decrease in the pulmonary vascular resistance. The blood flow is distributed in parallel, and progressively the fetal sands are closed. In this early age, the immature myocardium exposed to a high hypercontractile status sometimes is unable to support the increase in the afterload with a potentially decrease in the preload, resulting in a low cardiac output and an abnormal blood flow distribution. In this scenario, dobutamine, with its predominant B1 effect over myocardium, could improve the contractility without null or low effect in the afterload. However, the efficacy and safety of dobutamine versus placebo for circulatory impairment, defined by either hypotension or low superior vena cava flow in the low birth weight infant, has never been tested. This exploratory trial aims to gather information in the face of a therapeutic confirmatory trial with dobutamine for circulatory insufficiency defined as low superior vena cava flow. We included infants below 28 weeks of gestational age or between 28 and 31 weeks of gestational age with respiratory support if the informed consent was signed. We excluded infants with major congenital malformation at postnatal age beyond 12 hours of life at randomization, with dobutamine before randomization or if the informed consent was declined. Infants who were scanned in the first 12 hours of life and who presented low superior vena cava flow, defined as below 41 milliliter per kilo per minute in the first 24 hours of life, were randomized to receive dobutamine or placebo. The stepwise dose was increased till the time that the superior vena cava flow was at or above 41 milliliter per kilo per minute, every 30 minutes. It was considered therapeutic failure, so the drug was unmasked when infants achieved the higher infusion rate without achieving the threshold. The infants who normalized superior vena cava flow after randomization and those with normal superior vena cava flow at baseline was again scanned at 60 minutes to know superior vena cava flow stability. The follow-up continued till 24, 48, 72, and 96 hours of life, and at term equivalence. No trial of volume was administered per protocol before randomization. and the infants who achieved normal superior vena cava flow maintained the infusion rate till 24 hours of life. In this moment, the drug was unmasked and further treatment was at the physician's criteria. The primary study outcome was the rate of attainment and maintaining of normal superior vena cava flow in the randomized patient. The secondary outcomes was the short-term evolution of the clinical and biochemical parameters, also near-derived parameters, and cranial ultrasound Doppler studies. In addition, the main neonatal diagnoses were assessed at term equivalence. The superior vena cava flow was measured following the method proposed by Klukow and Evans. We randomized our population by two strata of gestational age, below and above 28 weeks. And this pilot study was not powered for any statistical objective. During 26 months, we enrolled 127 patients, representing 66% of the potential candidates. 28 infants were randomized to receive dobutamine or placebo with a mean age of 7 hours of postnatal age. 98 infants who presented normal superior vena cava flow during the first 24 hours of life represented the control group. As you can see, there were no differences between the main perinatal data between the intervention groups. However, as you can see, more infants in the dobutamine group have receiving cardiovascular support before randomization than in the placebo group. Although not statistically significant, potentially indicating poorer perfusion, poorer condition at randomization. Infants with low superior vena cava flow were more immature than control group and had receiving more advanced resuscitation at birth. No other differences were found between the perinatal variables. As you can see in this chart, it is represented the evolution of superior vena cava flow, near-derived parameters, and Doppler studies in the anterior and middle cerebral artery along the study period. All the infants except one achieved normal superior vena cava flow during the first 24 hours of life after randomization. As you can see, superior vena cava flow increased along the study period, however, independently of group allocation. The same profile was observed in relation with Doppler-derived variables, so a steady increase in the velocity with a decrease in the resistance indexes along the study period were observed, however, independently of group allocation. Nearest derived parameter didn't change along the study period. The mean blood pressure increased along the 96 hours of life independently of group allocation. However, the heart rate experienced a greater increase early after the infusion was started, statistically significant compared with placebo, and this increase was maintained during the 24 hours of life. In addition, the base excess was less negative in the dobutamine as compared as control group, and both later findings remain statistically significant after adjusting by epinephrine infusion. Survival was greater in the infants who did not experience low superior vena cava flow as compared with infants who did. In addition, Severe ischemic events were more frequent in infants with low superior vena cava flow as compared with control group. This was defined as vascular spasm or spontaneous intestinal perforation. However, when we adjusted for gestational age, only the later findings remained statistically significant. No other differences between the intervention groups were observed between dobutamine and placebo groups. In conclusion, low superior vena cava flow is a strong biomarker of abnormal blood flow distribution early after birth in the lower weight infants. The trends shown in this exploratory trial support better shorter outcome of biochemical perfusion parameters in the dobutamine-treated infants. However, a therapeutic confirmatory trial to assess the efficacy and safety of dobutamine for early hemodynamic insufficiency defined by older or novel biomarkers as low superior vena cava flow in lower weight infants is needed. We speculate the potential role of systematic volume expansion with normal saline prior to intervention, whether it could decrease the dobutamine side effects seen in this study as the increase in the heart rate. And I would like to thank the Spanish Healthcare Research Fund and the Spanish Neonatal Society for the financial support, and of course, the great effort that the research team put on this research project. And thank you very much for your attention.